Hello, and thank you for joining me for this case study following a total knee arthroplasty patient that I had the pleasure of working with. This is submitted for the class Clinical Kinesiology in the winter 2020 semester. So on to the purpose and background. The purpose of the total knee arthroplasty is to reduce activity limitation and participation restrictions through reducing pain, increasing range of motion, and increasing a person's functional stability. The total knee arthroplasty is indicated in the presence of severe joint pain, which this patient had a long history of, with several conservative measures failed, many corticosteroid injections over the years. When the patient has functional instability or limited motion, when the knee has developed significant deformity, or when articular cartilage has extensive damage. And this is another indication that this patient had over the years. Their diagnosis of osteoarthritis had caused the growth of osteophytes and caused damage to the articular cartilage. So this patient in question was a 56-year-old female with a dominant or right-sided total knee arthroplasty. They had a previous medical history of osteoarthritis, obesity, high blood pressure, diabetes, and COPD. So that combination of degenerative changes, increased joint loading, decreased circulation, decreased ability to heal, increased blood glucose, really provided the perfect environment for these chronic inflammatory degenerative changes. They had a history of pain lasting 6 years with a poor response to steroidal injections, and we had the pleasure of seeing them just 5 days following their knee arthroplasty. When we began to work with her, they presented with a range of motion of -10 to 83 degrees, which is pretty normal within, as we'll see, pretty normal ranges of motion for someone in the acute stages following this procedure. They had a strength in the 3s with a knee flexion of 3 out of 5, knee extension 3 minus out of 5, hip flexion and hip abduction 3 plus out of 5. And you're going to see a little later on that this patient had a lot of guarding and neurological inhibition, because in the testing position, hip abduction was measured 3 plus out of 5. But when we went to perform side-lying hip abductions, a level of assist was needed. We had to perform them supine for a day or so. Initial pain was 8 out of 10. That was controlled with opiates and muscle relaxers, along with ice packs that were self-applied 4 times a day. They were tender to palpation and demonstrated reduced sensation in distal anterior knee in proximity to the patella ligament. So some kinesiology principles here. The knee is instrumental to balance and fall prevention, following the kinetic chain of the foot and the ankle. The knee is the next place where we really see those fall prevention, those balance strategies start to play out. And as such, it's a priority to restore the normal range of motion. Postoperative edema and neuromuscular guarding can really contribute to altered kinematics. Given the repetitive nature of gait, it's so important to get our normal range of motion back and unaltered mechanics, so we don't have those chronic degenerative changes repeating on this fresh start. The knee consists of 2 articulations, the patellofemoral and the tibiofemoral, and those are encased within a kind of loose connective tissue, a loose joint capsule. Osteokinetically, the knee is a double condyloid joint with 2 degrees of freedom. Those degrees are flexion and extension that occur in the sagittal plane or in a medial-lateral axis. Those are the 2 that we have control over, knee extension, knee flexion, and then that second degree of freedom is rotation, which occurs in a transverse plane along a vertical axis. This is automatic and dependent on the asymmetrical joint system, creating the screw-home mechanism. There are some mobilizations that help maintain this, However, we did not have to use them in the case for this patient. Arthrokinematically, the patella slides superior with knee extension, kind of outside of the grooves in a very loose area, and inferior with flexion as the pressure of the patellar tendon and patellar ligament increases. There is also small amounts of medial to lateral translation. That's according to this Newman study published in 2017. You'll see later in the references. And when I say small amounts, they mean small. It's 2 degrees, I believe, medially, then 5 degrees laterally at various times during the movement of the kneecap. In open chain, the concave tibia slides in the same direction as the movement of the tibia. That's anterior with extension and posterior with flexion. So tibia on femoral extension, it moves, slides and rolls anteriorly, then posteriorly with flexion. In a closed chain, the femoral articular surfaces roll and slide in opposite direction. During closed chain flexion, the femoral condyles roll posteriorly while they slide anteriorly. So that's the movement we would expect to see with a squat. Postoperative swelling and scar healing can also inhibit range of motion and patellar tracking, causing aberrant patellar tracking during movement. Neuromuscular inhibition to quadriceps and increased co-contraction of hamstring is very common following surgery, and this can reduce anterior roll and increased articular compression during extension, resulting in reduced range of motion and maintaining a painful motion. Of primary concern of the muscles of the knee are the 3 hamstrings, the 4 quadriceps, and of the 2 triceps serrae, mostly we're just talking about the 1. Of course, there are other knees involved. The IT band, the tensor fasciae latae, and the popliteus are also intimately involved, and then of course many associated muscles up and down the chain. However, in this patient, it was mostly the calves, the quadriceps, and the hamstrings that were really of importance due to their reduced strength and extensibility. There are a lot of rehab principles at play following a total knee arthroplasty. We've already talked a little bit about range of motion and exactly why it's important. Ritter and associates in their 2008 study found that at least 105 degrees of flexion are necessary to rise from a normal chair, while 135 are needed for the most involved of activities, which apparently is getting in and out of a bathtub. This patient had a goal of 120 degrees of flexion, which allows for the majority of most of functional activities. And I'm sorry I don't know how to say this name. Cora Newitt and associates in their 2019 paper titled Recovery of Knee Range of Motion After a Total Knee Arthroplasty in the First Postoperative Weeks Poor Recovery Can Be Detected Early, found that range is gained at a nonlinear rate, and the largest gains are made in the first couple of weeks following surgery. And that's kind of the physiological time frame in which edema, anxiety, and pain start to naturally decrease. The average patient has a starting range of 80 degrees of flexion and negative 10.7 degrees of extension, which over the course of therapy increased to 110 degrees of flexion and negative 3.2 degrees of extension. If you'll remember how this patient started, very, very similar to those numbers, though thankfully we were able to push a little bit past 110 degrees of flexion and got them all the way past 120. Weight bearing is vital for several reasons. First is Wolff's law. Bones are going to remodel according to the stress that they're stimulated by. And depending on the design of the arthroplasty, you're going to want to weight bear to help the bones grow around the implant and really solidify it, make it nice and strong to help with that implant fixation. This, of course, will depend on the quality of bone, the health of the patient, design of the implant. In this case, the patient's weight bearing was encouraged during acute recovery, and because the clinical practice guide published by the APTA states there is insufficient evidence, but it remains best practice to develop a early mobility plan and teach patients who have undergone total knee arthroplasty regarding the importance of early mobility and appropriate progress of physical activity based on safety, functional tolerance, and physiological response. That's from page 1613. Then the next reason that weight bearing is so important is because it stimulates the mechanical receptors through the flesh and through the muscles, through the tissue, which is vital to increase proprioception and balance. The stimulation of those mechanical receptors through the lower extremity kinetic chain has been shown to be improved with progressive resistance exercise in ankles, at least, and that's from a 2012 paper by Smith and Associates. There is high quality evidence and strong recommendations for the inclusion of balance, walking, and movement symmetry interventions. The most clear evidence is for balance, and the guide recommends exercise that promote dynamic balance and movement symmetry, and that's on page 1614. The guide demonstrates that it is best practice, though there is insufficient evidence due to the difficulty and unlikelihood of their inclusion in any rehabilitative program, meaning no study is going to not provide a patient with range of motion exercises, which would, be a little unethical. Then we move on to strength, and we really want to reduce inhibition. One of the body's psychological or physiological responses to pain and especially surgery is to reduce strength to protect that site, protect those damaged muscles. Adequate strength is important to reduce the impacts of weight bearing by increasing the absorption time, thereby decreasing the impulse. This is the same principle as why certain types of cartilage are so good at force absorption, or why persons who are in high impact sports frequently wear some kind of protective gear to slow that impact time down, reducing the impulse. We know the neurological strength gains occur before hypertrophic, and many sources such as Kolbe, Kisner, and Borstad detail strength below similarly aged population in both involved and non-involved limbs for as long as 2 years following a surgery. The clinical practice guide identifies resistance and intensity of strength training within the first 7 days as soon as 24 to 72 hours post-surgery, characterized as the post-acute period. No routine or progression is advised within the exception that progression meets the criteria of not increasing baseline pain or soreness or excessive edema following therapy. The clinical practice guide also advocates for the use of neuromuscular education for the duration of at least 3 weeks if the neuromuscular inhibition is really severe. So there are 3 general protection phases following tissue healing and physiological adaptation times. We had the pleasure of seeing our patient very much in the maximum protection period, just 5 days post-surgery, so we're very much in that acute, post-acute healing period. This is how the patient will be presenting. We have weight-bearing per surgical guidelines. Our patient was full weight-bearing, or weight-bearing as tolerated, using a 4-wheeled walker with decreased range of motion, a little different range than we saw quoted earlier, because note that comes from a different source. This is from Borstad, Kolbe, and Kisner, and that was from a smaller study. Then some important things to look at, to be on the lookout for every visit. The examination points are abnormal gait patterns, pain, tracking that pain, those pain symptoms. And especially here in this maximum protection phase, we have these really traumatic red flag events. So those DVTs, those infections, those joint effusions, those hemarthroses. And luckily, our patient was pretty uncomplicated. We didn't have any of these negative effects. And that really could be because they were diligent about their home exercise program. They did all of the things to help control that edema and pain. They did their weight bearing, they did their active range of motion, the isometrics, which really helped increase that circulation, increase that Wolff's Law to help them get a good outcome. Here we can see some of the goals for each of the stages. Controlling pain and edema, vital here in that first stage to increase tissue healing and reduce the neuromuscular inhibition and the desire to, get out there and move. So let's get down to specifics. The patient had a fairly typical presentation, high pain controlled by medication, those opiates, muscle relaxers, as well as external application of ice packs. They received some post-acute home exercise instruction and gait instruction with a four-wheeled walker, and then came to us 5 days after surgery. Initial range of motion was similar to that reported by Cornut and Associates, lacking 10 degrees of extension and having about 80 degrees of flexion. Range of motion supported weight bearing and isometrics were instructed, and by their second visit, neuromuscular inhibition could be seen to have reduced, noted by the ability to produce a unassisted straight leg raise. Some design of replacements cause for delay of the sideline hip abduction to reduce joint forces and maintain replacement integrity. This patient was permitted to begin in the post-acute period. Patellofemoral mobilizations, soft tissue massage, inferential electric modality combined with elevation and ice packs were also used to reduce inflammation and pain reduction. Stretching of the calves and hamstrings, the hip flexors and IT band were luckily tested to be of normal length and didn't need to be addressed at that time. Began in week 2 once that acute inflammation reduced, and along with reduced impact aerobic exercises on an upright bike, constantly adjusting the seat to facilitate increasing that range of motion. So we see a pretty dramatic change, range of motion 10 to 83, then full extension to 128 degrees, which again allows them to do the majority of those functional things. They ended up with a gait free of deviation, and the patient was able to return to full function with no limitations or restrictions. So some conclusions from this case study. Care differed from the newly published clinical practice guide in just some very minor ways. And my big takeaway is I think I would like to work with gait just a little bit more. This patient had a reduced gait, and I certainly have a tendency to prioritize therapeutic exercise over gait, while the research made it very clear that the repetitive, stressful nature of gait really demands, good form to reduce chronic injuries down the road that I think I lose sight of sometimes. Another conclusion is the guide recommends 3 different outcome measures. Those outcome measures are the timed up and go and 30-second sit to stand test, in addition to the knee injury osteoarthritis outcomes survey joint replacement. That's the KOOS Junior. Our outcome measures at the clinic were the goals that we set, and then kind of a patient satisfaction survey. Lastly, the patient reported completing home exercise twice a day, 5 to 7 days a week. And that really indicates progressive resistance that may have been insufficient to elicit a hypertrophic response, certainly at that set and rep range. The neurological response did elicit an increase in strength, as we saw. Started at 3 negative, and we ended up at solid 4s all around. However, there were a lot of studies, some of which that we quoted, that said strength was still reduced following the surgery up to 2 years compared to a healthy population. So some instruction or some understanding of continuing progressive resistance exercises or difficult endurance gait activities, I think could really benefit these types of patients in the future. Here we have our references, and looking at this, I realized I forgot to really include the references or reference them in the presentation itself. So a really important one here is this study, and the outcome of this study said that different styles of stretching, static, passive, or PNF, all resulted in statistically similar gains in range of motion. The secret is doing it. So if one style is more tolerable or works better, or you know it better, it seems like it will be effective. Or better yet, a mix of all three. Definitely instruction to the patient on how to perform them when it's clinically safe to do so is very important for not only the rehab process but function in the future. All right, here's our second page of references, and we have one more study that we didn't really talk about, but it's really important for patients with lower extremity injuries, and that's speed and distance requirements for community ambulation. This study found that there were degrees of demands on speed depending on the community, depending on the patient, and that those speeds can range from about 1 mile per hour, 0.9 miles per hour, to 2.9 miles per hour, which would be for more of an open city, busy environment in which crossing streets against traffic would be more of a ADL activity of daily living. That's it. Thank everyone so much who stuck with me here. I hope this was elucidating and that you have a wonderful day.